All right, we're live now. Good evening, everyone. Good evening to all viewers, colleagues, and friends. My name is Magdalene, and I'm a speech language therapist from 20dB Therapy Tree in Kuching. And it's a great honor to have you join us tonight. And I think we have viewers from Malaysia and Singapore. We're going to give a few more minutes for more people to come in. And I understand we will have some viewers from other countries as well. So if you are from another country, could you please notify us by typing in the chat box? And also, as we go along the session today, please feel free to type in any questions you have, and we would do our best to attend to them towards the end of the session. So we're just going to wait for another minute before we start today. Okay, so in conjunction with 20dB's 18th anniversary and in collaboration with Speech Therapy Work Singapore, we'd like to share tonight on a very important topic about nasopharyngeal cancer, NPC, and the effect of it on speech, swallowing, and hearing difficulties before, during, and after radiotherapy, why and how to manage. And so today, without further ado, I'd like to welcome and introduce to you my fellow colleague, Mr. Liu Junkok. Junkok, would you like to introduce yourself?
Thank you, Madeline, and good evening to everyone. My name is Liu Kok. I have been working at 20dB Hearing for 17 years as clinical audiologist. I have seen some new NPC patients with hearing loss and provide audiological management to them almost every year. And NPC is the fourth most common cancer now in Malaysia. I hope today's topic will provide more and useful information to you all in related to the speech, swallowing, and hearing difficulties in NPC. Yep.
All right, thank you, Junkok. Junkok and I, just for fun information, that we were actually classmates in uni, and it's really nice to be able to see him in this platform after 17 years. So, and also our next speaker, Mr. Yun Wai Lam, he is our senior from UKM. So this is like going to be like a mini uni reunion. And Mr. Wai Lam to me is a very inspiring swallowing guru in our region. And he's been training speech language therapists in our region in pertaining to swallowing assessment and rehabilitation. So without further ado, Wai Lam, would you like to come on?
Welcome, Wai Lam.
Welcome, Wai Lam.
Hi, everyone. Hi, Madeline. And hi, Junkok. Hey, thank you for introducing me. Good evening to all the viewers. Thanks for tuning in. I have some friends coming who are going to view from Indonesia, from Nepal, from Bangladesh, India, Taiwan, Japan as well. And could be some from USA if let's say they decided to tune in and skip their maybe not sleeping. All right. So I will try to make this presentation exciting. So all right. So right now we'll start the presentation. So the topic for today is a topic of interest to many people in Southeast Asia, as well as Asia as well, especially the Chinese community, because some people actually call it the so-called like the cancer that is more related to the Chinese, because especially the Cantonese, and I'm Cantonese. So it's an area that really I'm interested in, and I did a lot of research on this area, and even came up with some of the protocol to do treatment for patients with NPC. So I will start my presentation now. So just a bit of introduction about myself. I'm a senior principal speech therapist and director of Speech Therapy Works LLP. I'm a founder of Singapore Swallowing Specialist Network. This is a network that I do blog and provide information about swallowing. So if you're interested, you can actually tune in to follow my blog. And I'm also an invited lecturer at NUS Master in Speech Pathology. And I invented the Chin Ta Again resistant C-Ta swallowing exercise. The photo, you see me holding a yellow ball, is actually the C-Ta exercise. So if you're interested later, I give you a QR code for you to follow, to get to know more about this exercise. So you can go to my website to take a look. And my website currently is down, the main one, and the dysphagia one is still on. My blog is on dysphagia.sg. You can email me after this or WhatsApp me for more information or for to ask any questions is fine. But preferably WhatsApp message, and I'll try to reply as soon as I can, if possible. So if you want to find out more about C-Ta exercise, you can visit my blog or scan this QR code. Don't worry about the QR code now or the URL, because after this presentation, I'm going to put this handout in my blog. So I will give you the link. Then you can download the handout from my blog. Not to worry. So you don't have to take notes or whatever. All right. And we just started one new movement called the Global Dysphagia Movement. Ooh, sounds so grand. So this is a movement. The reason why we started this is I developed a C-Ta video during the circuit breaker, Singapore circuit breaker. Then the video I translated to Malay. Then posted on some international platform. Then surprisingly, there were a lot of people sent encouraging feedback on the video. So there are many countries, speech therapists from different countries, actually they are interested to translate the video into their languages. So it will benefit the people from around the world. So I think that's a good idea. So we decided, why not we come up with a movement? We work together, maybe one video, but many languages. Then when this can reach out to more people, I think we can create a better awareness in dysphagia. So we have now Singapore, Malaysia, Japan, USA, Taiwan, India, Bangladesh, Pakistan, Philippines, and hope to have more countries, all right, joining us. So currently, the only thing that you need to do is just email me and express your interest. Then I'm going to start one page in my blog for the Global Dysphagia Movement group. All right, this is our presentation of video disclaimer. Okay, I think it will be good to have a disclaimer, because at the end of the day, don't just use the information that you learn from here to self-diagnose purpose or self-treat or for any reason. You still need help from the professional. Make sure that you seek the right advice so that you won't do it wrong, all right? So the outline for today's presentation, for my part, is what is NPC? Understanding the normal speech and swallowing process, why speech and swallowing difficulties might develop before, during, or after radiotherapy in NPC, and what can be done. Hearing loss in patients with NPC will be presented by Mr. Liu, and how do speech therapists manage speech and swallowing difficulties in patients with NPC? And can speech and swallowing function be preserved after radiotherapy? Wow, I think this is a very interesting topic, isn't it? So let's start the presentation. What is NPC? So NPC refers to cancer at the back of the throat behind the nose. So if you look at this picture here, so it is exactly right at the back of the nose, but it's still part of the throat, but it's in the nose region, all right? And the sign of nasopharyngeal cancer include trouble breathing, because if, let's say, you block this part, you might have difficulty breathing through the nose. So a person experiencing this might end up breathing through the mouth. Difficulty breathing, because if it's blocked, then you find that it's difficult to say certain sounds that require the nasal sound, like mama, the M sound, like nose, the N sound, will be difficult to be pronounced. And hearing, if let's say you block the eustachian tube, then what happens is that there might be water retention in the ear, then causing some hearing difficulty. Dr. Jun Kok is going to present more on this later. And there are three main treatments for NPC. Radiation therapy, the most common one. Chemotherapy, sometimes it's used together with radiation therapy. And surgery. Surgery is not so common. I think surgery usually is more for those who are more at the like a stage 4 or advanced stage NPC. All right. Before we move on to find out more about the difficulty, let us understand the normal speech and swallowing process first. These are the structures important for speech and swallowing. All right. The nose, you need to speak certain sound through through the nose, like the M sound, N sound, as I mentioned earlier, the nasal sound. You need the mouth, the tongue to articulate certain sound. All right. In fact, most of the sound, the lip, the teeth, the palate, all play an important role. You need the voice box, the vocal cords to vibrate to produce voice, and you need the power source, which is the lung, to push air to vibrate the vocal fold. All right. To speak out loud, you actually need your lung power to push more to produce louder voice. And then, of course, all these structures are controlled by the brain. So how much to talk and how well you talk and how soft you talk and how loud you talk or how high pitch is all can be controlled by the brain. All right. So this is just to illustrate to you. If we look into all the structures, right, it lies all the muscles that are important. And all these muscles are interrelated, and then they are all linked by the nerves, and they all are controlled via the brain. Okay, so the mouth area, you can see all the little dots actually referring to the sensation. What happens is that if let's say any part of these muscles are affected, it might affect your speech, it might affect your swallowing, because speech and swallowing, we need our mouth to eat, we need our mouth to eat to speak as well as the throat, and then the nose as well. Okay. So how speech is produced? I mentioned earlier, you need the lung to push air out. Larynx is the voice box area. This is where voice will be produced when the air pushes through the vocal fold. Then in our mouth, we articulate with our tongue. Then the nose will be involved in saying certain sound. All right. So what happened is that the area that is really mainly affected by radiotherapy is the area whereby the radiotherapy will be beamed through, which is around this region. So because the radiotherapy is targeted that area, muscles, nerve around the area might be affected during radiotherapy. So now we try to understand how we swallow. Well, swallowing is controlled by the brain, just like the speech. Involve 50 pairs of muscle. Wow, 50 pairs. When we swallow, we eat, we drink, eat KFC, everything. No need to think about 50 pairs. We thought there's only one pair. Just swallow, then that's it. But you will never imagine there are actually 50 pairs of muscles. And there are 5 major pairs of cranial nerve involved, the nerve that is involved in swallowing. And all 5 are very important. And there are 2 types of swallowing. Automatic swallowing. It's just like, if I were to ask you, how long did you spend or how many swallows did you spend to finish a bowl of rice? You probably cannot even imagine how many swallows that you did and how fast you managed to swallow, or even think of you can't even remember that actually you finished eating until the last spoon that you were scooping up. All right, that's because those swallowing is more automatic, so it's unconscious. But we can have conscious swallowing as well. So conscious swallowing is like, if let's say you all try to perform this together with me, try to swallow saliva. Okay, so if you are swallowing saliva on my command, you are doing it consciously. So it's conscious swallowing. So this is the process of swallowing. After you finish chewing, in the picture A, you start to push the food backward. So the tongue will move up, touch the palate, squeezing the food in this direction. So once the food reaches the throat area, you notice that the soft palate is closed. Why the soft palate is closed is because we are programmed in such that we try to avoid food entering the nose. But then again, I'm pretty sure every one of you might have experienced water entering the nose, food entering the nose at any part of your life. It's partly because sometimes we cannot be 100%, normal. Sometimes we might experience discoordination as well. But then those are pretty normal, all right? So food will be prevented from entering the nose. Then you realize that this flap here at the throat, it starts to flex down and all the way down. This is when airway will start to be protected by this area. So our airway will be closed, shut food will start to enter the throat, then into the gullet, the food pipe. Then once it passes the throat, enter the food pipe, then the flap will start to open back, the airway will open again. This is the reason why when you swallow, you can't breathe. And also this is the reason why our parents ask us, don't speak and eat at the same time, because when you speak, your airway still need to open to vibrate. So when you swallow, you might get choked more easily. All right? Oh, then this is the most important part that everybody would like to know more. Why speech or swallowing difficulties might develop before, during, after radiotherapy in NPC, and what can be done? All right, if you look at radiotherapy, so it's very targeted. So usually it will be more targeted for NPC cases towards the nasopharyngeal area. But then again, the beam will still get through, will have to go through the neck area. So the muscles area, for example, like if let's say it is around this region, right, around the nose area, then the muscles and the nerve which is surrounding that area will get exposure. In the olden day, before the year 2000, the radiotherapy is actually not targeted. So those patients who were radiated during that period of time usually come back with a lot of side effects. The whole neck is very stiff, the neck cannot turn, the tongue turns stiff, and usually the degree of like severity of speech and swallowing difficulty is more severe. But then again, since IMRT, which is introduced around year 2000 until now, we are still using IMRT. It is more targeted, but we are still seeing the speech and swallowing side effect on speech and swallowing. So reason is because when we beam through, the swallow muscles, most of the swallow muscles and the speech muscles are exposed as well. And then the nerve might be affected. So muscles might get stiff over time, fibrosis. So question now is that why speech and swallowing difficulties can develop even before radiotherapy? Because if NPC is diagnosed, so usually it's not common, all right, to be very frank. Speech and swallowing difficulty may be present at the time of NPC diagnosis if cranial nerve involved in speech and swallowing control are affected. For example, if you look at this, right, the red color spot here is actually referring to, let's say, the tumor area. But you also see that nerves can actually pass through that area. If it's the NPC presses on the nerve, it will cause the nerve to be dysfunction. So if let's say it's controlling, let's say, the cranial nerve 10, then the voice might be affected. If let's say it's controlling like the nerve 7, then the face muscle might be affected. All right. Then if let's say it is occluding the whole area, then our speech will be affected as well, because then we can't say certain nasal sounds. Okay. So it can also happen during and after treatment. Why is it so? Because effect of radiation on speech and swallowing function may vary. Some people have very significant effect when during treatment, whereby it's in rare condition. I even see like nerve problem, which is like very rare, because it's like you can probably see 1 in 100. I mean, this is based on my experience, and then it was like really a significant effect. But then usually our nerve is actually radiation, so-called like resistance. It wouldn't get quite immediate. There are some other longer term process that may affect the nerve, but definitely not like direct exposure. But we have seen cases who are like quite immediate. Then long-term radiotherapy can lead to muscle fibrosis, muscle swelling, and damage to the nerves. So muscle fibrosis is referring to when the muscle have start to turn stiff. Then usually what happens is that muscle fibrosis, once it happens, then a lot of the research and literature say that it is irreversible. And if it's possible, right, try to prevent it from happening. I will talk about how to prevent this at the end of this lecture. And usually these problems are not picked up until several months or years, or after its onset of the radiotherapy. Okay, so during radiotherapy might include chemotherapy as well. So people who went through like chemotherapy with radiotherapy oftentimes develop mucositis. So it is referring to inflammation and ulceration in the mouth. If you look at the first picture here, below here, mucositis, you get to see all the ulcers and then all the white patches there, all the inflammation happening, and it is very, very painful. some pain to the extent that they can't really eat. So it is important to take note that actually, if this is happening still, we still have to make sure that you get enough nutrition. All right. I'll talk about why nutrition is important later. And it can cause very dry mouth. When dry mouth is really happening, we will try to manage it. I will talk about how to mention dry mouth later. And we rarely see muscle fibrosis or damage of the nerve at the beginning during the radiotherapy, but we have seen before. So what happened if, let's say, during radiotherapy that you develop dry mouth, or we call it xerostomia? First thing is that try to make sure that you perform oral hygiene after each meal and before bedtime, okay? Because food trap, then you want to make sure that it's clean so that you also want to prevent bacteria from growing. And when the mouth is too dry, right, no saliva, the pH inside our mouth is actually become, it will change. And the teeth tends to decay even more easily. So you have to make sure that you maintain good oral hygiene. Keep water handy at all times to moisten the mouth. You can, if let's say you don't feel like using any other things, then just at least drink water whenever you are. And use artificial saliva like Oral 7, Oral 7 moisturizing gel. This one, we use it a lot in Singapore. And if let's say you are using like mouthwash, make sure that you avoid alcohol-based mouthwash like Listerine. Those alcohol-based one is going to dry up your mouth even more. So try to avoid using those. So instead of using those, you can consider using Oral 7 mouthwash. And what if, let's say, there's pain when chewing and swallowing due to inflammation and ulceration? Okay. As I mentioned earlier, maintaining good nutrition is a must, because during those periods, you need to recover, your cell need to recover, okay? So you have to make sure that nutrition is sufficient. And bear in mind, the mask for radiation is to fit you nicely so that you don't make much movement so that the radiation can be targeted. You just imagine if, let's say, you start to lose weight, your face shrunk in size, your shoulders start to lose muscle mass, you can't stay still. So the radiation might not be as targeted as, because it was molded based on your previous body size, right? So it is very important to maintain your weight. And another thing that you can do, if let's say there's any pain on chewing or swallowing, you can eat foods that are easy to chew or swallow, like porridge, minced meat or vegetable, soft fruits such as banana. Cut foods into small pieces, avoid foods that irritates the mouth. For example, like some people like me like to eat sour plum. Wow, but then sour plum is really causing a lot of pain. Then just avoid eating sour plum. I like to eat curry as well. So the spicier, the better. Then avoid eating curry, maybe during the period of time. Eat foods as cold and at room temperature. Well, you know, Chinese, they can drink the soup boiling hot. So the Chinese have to probably start to put some ice inside the soup as well to cool it down, okay? So another thing is that we have to modify diet and thicken up fluids if there's a need. So modified diet is referring to like whether you need to blend, you need to mince, or you need to smoothen it, make it softer, or thicken up the fluids. This one need to be advised by the speech therapist. So if let's say there's a need, see your speech therapist for advice. Okay, what about if let's say still pain and chewing, then if pain is unbearable, right, and it's affecting your oral intake, you really cannot swallow. It's not that you don't want. Swallow, just cannot. Then do consider tube feeding. Try to avoid having like I don't want tube feeding. That's why I avoid everything. So I think the effect will be worse after that. So bear in mind, a lot of the time, all this pain might be just temporary. After the treatment, then it might be back to the swallowing might regain back. So it might just be temporary, just for the period of time you might need that. Another thing that you can use is to numb the mouth with ice chips, ice cream, or flavored ice pops. All right, I think that's not a bad idea. I would love that. Supplement meals with high calorie, high protein drinks. Like Fortisip, you can use like a high protein kind of like diet. Ask your dietitian for advice. What about dry mouth? For late effect, it is exactly the same as when during radiotherapy. So I wouldn't talk further about this because it's exactly the same. Okay, this one is something that might develop as a late effect of radiotherapy. The taste bud, they might patients might experience altered taste sensation. Sometimes they might taste a bit metallic. Food might taste a bit metallic. So if let's say that's the case, or it really changes your appetite, you might want to eat small, frequent meals and healthy snack. I mean, we eat more when we have appetite. We will still eat if let's say the food is there, right? So in that case, then you break it. Okay, I just eat smaller amount. Maybe instead of like eating once every 4 hours, now you eat every 2 hours. Then you break into half each. Okay, so you still eat frequent meals, but healthy snacks. I mean, don't snack on potato chips and all this. And if let's say your taste bud or the food tastes metallic to you, you try to avoid using the metal spoon. Use plastic utensil as instead. And use sugar-free lemon drops or mints when experiencing a metallic or bitter taste in the mouth. And try to avoid food. Try to use favorite food try to use favorite food to enhance your appetite. Okay, what about bad breath, halitosis? Okay, this is a common side effect. And what causes halitosis or bad breath? It is usually caused by the accumulation of sludge at the back of the nose. Okay, why this develop? Okay, so firstly, mouth also play a part. If let's say your mouth is dry all the time, it can cause bad breath. But the really significant bad breath and the very strong smell actually usually come from the nose, at the back of the nose. Remember that I told you the food can enter the nose if let's say the soft palate doesn't close. Later I will show you the picture of it. So in order to prevent this, you keep your mouth as moist as possible all the time. Perform nasal wash after each meal. So you just flush the water through the nose and then let it come through the other side of the nose, so that all the dirts or the food residue will come out from the other side. Some of the patients, they put sodium bicarbonate so that it will help to wash up even more easily, especially those food residue. Okay, so this is one that I saw from Taobao, this picture, or Amazon. You can go and take a look. There are different types you can buy from online nowadays. So if you look at this picture here, this picture shows a normal swallowing. When the food, the first picture on the left, if you look at it, if let's say during swallowing, right, the soft palate is closed, approximating the back of the throat muscle. So what happened is that the food will be prevented from entering the nose. But in this second picture here, you see that the soft palate doesn't approximate the back of the throat. So what happened is that the food enters the nose. So food will start to accumulate around this area. So over time, it turns into sludge, and then it is very strong smell. And ENT management, sometimes they put in the scope with like a faucet. They will slowly take out bit by bit. But then again, I've seen patients who went through that procedure, the smell is still there. So if possible, try to prevent this from happening. All right? Okay. These are the important things to note. All right? That's why I put it green. Well, green is not like alarming kind of color, but I like green. So let's view this as important. If you see these symptoms, please go and consult an ENT doctor or speech therapist. Voice change. Suddenly the voice turned hoarse. A lot of nasal sound. Voice sounds like coming out from the nose, or soft or breathy, like breathy voice, as in like, I think I can't even speak properly because my voice, I lost my voice. These are breathy voice. All right. A lot of patients with radiotherapy, the late effect, one of the common symptoms also is like their voice turn breathy. So usually there is also an indication that certain nerve or one side or two sides of the vocal cord is actually not functioning that well. All right. And poor speech intelligibility, meaning that the speech is not very clear. When speak, it sounded slur. Sometimes can't really articulate very well. The tongue tremor, the tongue start to tremor. And restrict mouth opening, the mouth can't really open that well. Okay, so food and liquid coming out from the nose, food sticking in the throat, the food keeps stucking in the throat. Then you need to drink a lot of water to flush down. coughing and choking when eating and drinking, this is a very serious presentation. If let's say it is very common, especially for those who have went through radiotherapy, please go and see a doctor, especially the ENT or the speech therapist. Taking longer time to finish a meal, well, the record that I've ever heard of is 2 hours for one meal, and it's just less than a bowl of porridge. It's a watery porridge, so it can be that long. Reason is one scoop in, swallow, doesn't go down, start to choke and attempt to swallow again. So just one spoon itself, it might take like 5-10 minutes to struggle to swallow down. So if possible, even like the mild presentation or like food stick here but still can eat, start to see the speech therapist and start to seek help, so that hopefully we can try to prevent the condition from worsening too rapidly. And avoid certain food, for example, like too dry or too big piece, then start to change the diet pattern, eating only porridge or eating only soupy things. Then those are like some pattern that we might see. Difficulty in breathing after eating and drinking together with flu-like symptoms such as like fever, chills, drowsiness, increase in phlegm. And these are the chest infection symptom actually. If these symptoms are noted and it is frequent, because I've got some client came and see us only after like this become a huge issue, causing them to come to hospital because of chest infection. I mean, usually when this happens, the swallowing condition is actually severe. So don't let the swallowing condition turn severe before you seek help. All right, now it's time to pass the mic back to Mr. Liu. He will be talking about hearing loss in patients with NPC. All right, Mr. Liu.
Okay, thank you, Mr. Yun. Okay, thank you, Mr. Yun. So now I continue my topic on hearing loss in patients with NPC in audiological point of view and management. Okay, this is the outline of our topics. Includes signs and symptoms of NPC, how do we hear, types and degree of hearing loss signs and symptoms, why hearing loss might develop before, during, and after radiotherapy in NPC. And the final part will be on audiological management for NPC after medical clearance. Okay, on signs and symptoms of NPC, in its early stages, NPC may not cause any symptom. At the late stage, possible noticeable symptoms of NPC includes lymph nodes enlargement in the neck, blood in saliva, sore throat, nosebleed, nose blockage, facial pain or numbness, blurred or double vision, trouble breathing or talking, trouble opening the mouth, and the other part related to the hearing is hearing loss, ringing in the ears, frequent ear infection, feeling of fullness in the ear, and usually this is on one side, or we call it unilateral. Okay, now we come back to the basic knowledge on how do we hear. Our ears divided into three parts, which are outer ear, middle ear, and the inner ear. Okay, so at first, sound wave enter the outer ear and travel through the ear canal to the eardrum. The eardrum then vibrates with the incoming sound and send the vibration to the three tiny bones in the middle ear. The bone in the middle ears amplify the sound vibrations and send them to the inner ear. The sound vibration activate tiny hair cells in the inner ear, which in turn release neurochemical messages. Then the auditory nerve carry this electrical signal to the brain, which translate it into a sound we can understand. So this is how we hear. Okay, now we come to the types and degree of hearing loss. Hearing loss is caused by damage to one or more parts of the hearing system. The type of hearing loss depends on where the damage occurred. Okay, this is the structure of the ears. There are three types of hearing loss, which is conductive hearing loss, sensory neural hearing loss, and mixed hearing loss. Conductive hearing loss occurs when there is damage or disease in the outer or the middle ear. This includes the pinna, ear canal, eardrum, or bones in the middle ear. Conductive hearing loss can sometimes be corrected with surgery or medication. So this is very important that if the hearing test result shows there's any conductive element, this is a must for the audiologist to refer the patient for medical clearance before proceed with the audiological management. Especially nowadays, people might do the hearing test online and directly proceed with the hearing aid fitting without any diagnostic test. This might cause the delay of medical treatment if their hearing loss is due to the medical condition. Here, I advise every one of you to go to the hearing center with qualified audiologists to get the hearing test done to avoid any complication happen later. Okay, conductive hearing loss can cause by fluids in the middle ear, otitis media, which is very common in NPC patient, damage to the middle ear bones, damage to the eardrum, earwax, birth defects like microtia, atresia. Okay, now we come to the sensory hearing loss. Occurs when there is damage to the inner ear, the cochlea, which is this part. Sensory neural hearing loss is usually permanent and cannot be corrected. So hearing aids and other assistive hearing technologies can offer help this type of hearing loss. So sensory neural hearing loss can cause by natural aging process, genetics, exposure to loud noise, medication that are toxic to the ears, traumatic injury, and illnesses. Okay, mixed hearing loss is a combination of both conductive and sensory neural hearing loss. Therefore, both the outer or the middle and the inner ear are damaged, and this will cause a mixed hearing loss. Degree of hearing loss refer to the severity of loss and are generally described as mild, moderate, moderately severe, severe, or profound. The loudness of sound is measured in units called decibel, or in short, dB. For example, whispering occurred in 15 dB. Normal conversation is 40 to 60 dB. Rock concert, 120 dB. Gunshot at 140 dB. Okay, this is the classification for degree of hearing loss. People with 20 dB or below are in normal hearing category. Our company name, 20 dB, as you can see the logo here, is to remind everyone that we should protect our hearing, maintain at 20 dB or below, as 20 dB is the borderline for normal hearing. So those who have hearing at 21 to 40 dB considered to have mild hearing loss, moderate hearing loss at 41 to 55, moderately severe hearing loss is at 56 until 70, 71 until 90 is considered as severe hearing loss, and 91 above is considered as profound hearing loss. This is categorized for the degree of hearing loss. Okay, this is diagram show the familiar sound. Okay, so the top part here, 0, 10, 20, considered soft sound. Like whispering is at 50, as I mentioned just now. Conversation, okay, this is a speech sound, 20 to 60. Okay, this is the loud sound, rock concert, gunshot. So what happened to people who has mild hearing loss? A person with mild hearing loss may hear some speech sound. Okay, if you can see here, as I mentioned, it's 21 to 40. So person with mild hearing loss may hear some speech sound, but soft sound are hard to hear. For moderate hearing loss, a person with a moderate hearing loss may hear almost no speech when another person is talking at a normal level. Those with moderate severe hearing loss need to ask people to repeat themselves during conversation, both in person or on the phone. A person with severe hearing loss will hear no speech when the person is talking at a normal level and only can hear some loud sound like traffic noise, A person with profound hearing loss will hear no speech and only can hear some very loud sound, like firecracker and also the gunshot sound. Okay. Hearing loss signs and symptoms. Hearing loss may occur gradually over many years and suddenly, and its duration can vary. Hearing loss can affect an individual socially and emotionally. It can make communication with family and friends difficult. When untreated, it can lead to the stress from straining to hear, embarrassment from misunderstanding others, and eventually withdrawal and isolation. So audiological management is very important to people who suffer from hearing loss to improve their quality of life. Okay, here are the signs and symptoms of hearing loss includes increasing the volume of the radio or TV, difficulty understanding others in the presence of background noise, frequently asking others to repeat what they say, people sound like they are mumbling, and avoidance of social situations. Here's some of the examples. Okay, now we come to the main topic today. Why hearing loss might develop before, during, and after radiotherapy in NPC. As I have mentioned early stages of NPC may not cause any symptom. At the late stage, possible symptom of NPC like hearing loss, ringing in the ear will be observed. How actually this happen? Okay, so at the late stage, NPC can grow and press on one of the two eustachian tube. So this is the NPC. So if you're pressing, this is the eustachian tube. So at the late stage, the NPC will pressing to this tube. This tube, actually, the function of this tube is to help regulate pressure in and drain fluid from the middle ear. So the growth of NPC will cause the eustachian tube getting narrower and finally close up. The fluids accumulate in the middle ear and cause otitis media. The fluids might rupture the eardrum, causing ear discharge. All this will cause conductive hearing loss, and some will experience ringing in the ear as well. Okay, so during radiotherapy in NPC, some types of surgery and radiotherapy for NPC can cause swelling around the eustachian tube. And again, this will cause otitis media. In some cases, patient hearing will get back to the normal once the swelling goes down. And also during the radiotherapy, some radiotherapy for NPC can cause damage to the inner hair cell and hearing nerve that send message to the brain. This damage will cause sensory neural hearing loss, and this may be permanent. Okay, so this is the hearing part, and any damage to the nerve here will cause the sensory neural hearing loss. So this might happen during the radiotherapy for NPC. So after the radiotherapy in NPC, the most common complication after radiotherapy treatment for NPC were found to be eustachian tube dysfunction, and again, otitis media in this case. Radiotherapy for NPC that cause damage to the inner ear hair cell to some patients after the treatment will cause sensory neural hearing loss. If the radiotherapy for NPC causing the eustachian tube dysfunction and damage to the inner hair cell after the treatment, then this patient will have mixed hearing loss. Okay, the hearing loss developed before, during, and after radiotherapy in NPC is varied from individual, depends on the size of the NPC itself, treatment method, and other health conditions. Some might not have any hearing loss. Some may only have conductive or only sensory neural, or both mixed hearing loss. Okay, now we go to the audiological management for NPC. After medical clearance, normally the specialist, especially ENT doctor, will refer their patient for audiological management if their patient shows some degree of hearing loss. So the patient will come for the audiological management. They will go through this process. Includes hearing assessment, pre-fitting counseling, hearing aid selection and prescription, hearing aid fitting and orientation, follow-up, include hearing aid verification, hearing aid validation, fine-tuning, monthly, quarterly, yearly review, and finally, hearing aid servicing. Okay, in hearing assessment, full hearing diagnostic tests will be carried out, including otoscopic examination to check the outer ear, tympanometry to check the middle ear, and finally the hearing test, we call it pure tone audiometry, to determine the type and degree of hearing loss. In pre-fitting counseling, during this counseling session, audiologists will explain a general issue pertaining to hearing aids and hearing loss, such as expectation and limitation of using hearing aid. Audiologists also address all inquiries or relevant issues during this pre-fitting counseling. Next is the hearing aid selection and prescription. Audiologists will introduce several options of hearing aid to patients after considering the factors below, before recommending the hearing aid that are most suitable. So the factors include type and degree of hearing loss, age, budget, lifestyle like occupation, social activities, comfort and visibility of hearing aids, and also a condition of the ears. In this session, hearing aid trial is possible to allow patients to try on the recommended hearing aid before they do the selection. Okay, these are the style of hearing aids which we will recommend for the patient. For MPC patients, normally we recommend behind the ear types of hearing aids because it's easy to manage, especially normally they need the volume control and this behind the ear type will provide sufficient power to help them to hear better. And also due to the ear discharge issue, then the behind the ear type is the most suitable because the ear discharge might damage the other types of the hearing aids, especially the inside the ear types or receiver in the canal. So this one we seldom recommend. What we recommend will be the behind the ear types. But for those who have repeatedly ear discharge, so the most suitable type will be the bone conduction hearing aids. Okay, now come to the hearing aid fitting and orientation. During the hearing aid fitting session, audiologists will ensure amplification signal does not exceed level where the patient complains it to be too loud or too soft. At initial stage, audiologists will set lower amplification level that allows patients to adapt to the use of hearing aid. And during the orientation, audiologists will guide them on how to operate the hearing aid, change of volume, programming the hearing aids, and perform daily general care on hearing aids. How to insert the battery, how to insert ear mold and remove the ear mold from the ears. Audiologists may also involve caregiver on this orientation session, especially if the patient are the elderly person. Audiologists will brief on the hearing aid warranty issue and post-fitting follow-up in this session. So next is the follow-up session. So during this session, audiologists will adjust and fine-tune the hearing aids sound setting according to the patient's feedback until the patient has adapted to the amplified level. So during the follow-up, we also will conduct hearing aid verification and hearing aid validation to ensure that the hearing aid is at its most suitable level to use by the user. And then the audiologist will schedule the appointment by monthly or quarterly follow-up for the first 2 years, and then follow-up by the yearly review. And this depends on the patient's ear's condition as well. Okay, last part will be the hearing aid servicing, like listening check, cleaning, general service. This is to ensure the hearing aid is well functioning. Okay, now we come to the summary. Okay, proper audiological management. Okay, in summary for the hearing loss in patient with MPC, Conductive hearing loss is the most common in NPC secondary to the otitis media before, during, and after radiotherapy. Sensory neural hearing loss may develop during and after the radiotherapy due to damage to the inner hair cell. Proper audiological management after medical clearance able to help NPC patients with hearing loss to improve their quality of life. And early amplification can help NPC patients with hearing loss to prevent auditory deprivation. Okay, this is my part. Now I pass back to Mr. Yun to continue his topic.
Topic here. Thank you very much, Mr. Liu. It was an interesting presentation on audiological management for NPC patient. I find it very interesting because, I don't usually follow up on what exactly is being done during their audiology consultation. Everything. I think it's very important that to make sure that it's being managed well by the audiologist for someone who have gone through radiotherapy. So now is the last part of my presentation. How do speech therapists manage speech and swallowing difficulties in patients with NPC? Well, I'm talking based on the context in Singapore. Well, I believe that different countries has got a different way of managing cases. So we can share our way of managing, then perhaps we can learn from each other. We can have a different session on this. So how do speech therapists manage here? So first, we do assessment, clinical bedside evaluation. We provide different types of texture for patient to try out different type of food and then see how they present their symptoms and then see if, let's say, what are the suitable texture of food or fluid that might be suitable for the patient. If, let's say, patient is not safe for oral feeding, then we might recommend tube feeding, while we might send patient for further investigation, like the objective assessment, which is video fluoroscopy, VFS. Later, I will show you video fluoroscopy video so that you have an understanding on how it looks like and why we perform it. Then fiber optic endoscopic examination for swallowing fees. These are the two common objective assessments done in Singapore. So this is how VFS is done. So you can see here, the pink color is actually the chair, then fluoroscope and the X-ray tube. These are the machine that we use to perform the video fluoroscopy. Then the image will be shown on the screen. We will record it. This is how it looks like. This is the jaw on the X-ray, our cervical bone, then the throat area. The black color things is actually the liquid that the patient swallow. So on the right-hand side, you can see that all the white color stuff here, actually white color stuff is actually barium powdered. We put into the food or the fluid to dye it up so that on X-ray, it will look black in color. Okay, later I will show you the video video fluoroscopy video together with the other video. All right, together with FEES video. This is a picture of me performing FEES for one of my friends. We use an endoscope and then we scope through the nose all the way to the throat. Then we'll view the throat while we feed the patient with different type of texture. And usually we put color dye into those food or the liquid so that it can be seen more clearly. So I will show you the video now. So this is a video of video fluoroscopy and how well a person swallow when it's normal. So this is how it looks like. So this is the jaw. Okay, hang on because the video is not up yet. Okay, it's a bit delayed. All right, this is how the video looks like. Video fluoroscopy, this is the jaw. This is the mouth area. This is the throat area. This is the airway. So this is the backbone, the cervical bone. So when a person swallow, right, this is a normal swallowing. So basically this normal swallowing shows that the food will just glide in nicely without leaving even a single residue. So the person is chewing. So when the food is ready, right, the tongue will just push it all the way through into our food pipe. And this is a normal swallow. Okay, now I'm going to show you an abnormal swallowing. Okay, this is okay, while waiting for the X-ray or the VFS video to be loaded. So this is exactly, and this is actually an NPC case for this particular video. So this patient is actually eating rice. All right, it's a bit slow. I think partly because it's a video file. So hopefully, okay, there you go. It'll be loaded soon. All right, there you go. So you can see there's already some food residue inside the throat. And the patient is chewing. Okay, food is going down. Pay attention at this area, whereby whether the food enters the food passage or not. It's so little. And then there's so much food that's stuck inside the throat. See, all these are the rice that is stuck inside the throat. So what should we do? Then what happens is that this patient has been taught to actually use water to flush down with a technique to protect the airway. Have a look. Okay, patient is drinking water soon. So pay attention at this airway here. Okay, as the patient swallow, right, you notice that food are now going down the food passage, but there's still a lot of residue inside the throat. At the same time, there are already some food or liquid entering the airway. But this patient managed to actually protect the airway and then prevent it from entering further down, which is the lower airway. And if further down will be the lung. Okay? All right. So I will continue with my presentation. I will show you the fees. How does a fees look like? All right, this is this is a fees video. This is the airway. This is our throat. This is from a different angle, from the scope angle, and this is our tongue. Okay, the food basically is dyed with a green color. All right. So you see that the food is entering the throat. The drink, actually it's a drink, it's not food, okay? The fluid entering is a big green color because we put food coloring, green in color. And we are trying to see these patients actually swallow quite delay. So that's why you see that he didn't really swallow until after a while. So after that, then we try to check whether there's any fluid entering the airway. And this is important because this is to ascertain whether is it safe for the patient to continue eating or drinking. So we have to make sure that safety is a priority as well when managing cases like this. All right. So I will close this video. I'll continue with my presentation. So before starting chemo or radiotherapy, what will speech therapists do? So we assess speech and swallowing function and recommend diet or alternative feeding method. All right, for example, like whether there's a need for nasogastric tube, the tube feeding, or there's a need for swallowing strategies as appropriate, whether any strategy can ensure that the swallow is being swallowed safely. Sorry, the food can be swallowed safely, and counseling on the possible immediate and long-term side effect of chemo or radiotherapy and ways to manage should those side effects occur. You see, the thing is that when I first started working as a speech therapist, those years were 2001. So those patients, when I first saw, right, are those patients who didn't go through IMRT, but those like the old type of like radiotherapy, which is like it will just blast and there's not focus. So what happened is that we see those like really significant side effect from those radiotherapy. So a lot of the patients come to us and then start to say, why this is happening to me? And why we were not told that this is happening, this is going to happen, and there's such side effect, I would have chosen not to do it. So you see the impact just psychologically on patients who are experiencing such side effect is so great. And once their quality of life is affected, then that's where seriously emotionally, psychologically can really like dampen significantly. So I think it's very important to inform, because right now we are entering the new era whereby for cases who have gone through radiotherapy or even before, we encourage to do some therapy exercises to prevent or actually to preserve the speech and swallowing function. I will talk more about this later. What about during and after chemotherapy? We do assessment for speech and swallowing function as well. We try to recommend diet or alternative feeding method or swallowing strategies as appropriate, because during and after, they might start to experience different kind of problem, which I mentioned earlier. Then we try to teach exercise to preserve swallowing function. And this is whereby in the era whereby more and more research is coming out. And we notice that the research shows that actually it helps to kind of like maintain flexibility of the muscles and also potentially prevent swallowing function from worsening. Of course, there are more work to be done, more research to be done to try to find out if, let's say, it is really like helping more on a long-term basis. But definitely, I must say that based on my personal experience, like because I conduct talk to the Nasopharyngeal Cancer group in Singapore, those cancer survivor, they actually, I noticed one thing is that there's one NPC survivor who is a triathlete. He went through the old type of like radiotherapy. Actually, until today, right, his function is still preserved after, I think, more than 20 years, which is quite amazing. Because why? He maintained an active lifestyle. So after radiotherapy, tell yourself, if let's say you went through that, life goes on, maintain even healthier lifestyle. Make sure that more exercises, the preserved swallowing function exercise must do. Then when you do it, the muscle got worked out, then more blood circulation, muscle might be healthier. So you hopefully can prevent those fibrosis and all those unnecessary changes. So teach exercises to improve muscle strength or movement. We teach that as well. Refer patient to other professional for further management if necessary. Okay, if let's say the speech impairment is only mild, we do oral motor exercise. We try to teach all the muscle movement, all the movement for the tongue, the lip, everything. Hopefully we can try to preserve the function as much as possible, and or try to prevent it from worsening so rapidly. Compensatory strategies, how to talk more clearly with a strategy. All right. And if let's say the condition becomes severe, like the speech become unclear, still we'll try to advise to perform motor exercises. So for as much as like the tongue can move, we try to push to do more. Hopefully we can still maintain the function. Compensatory strategies is the same. We will still try to teach as much as we can to make sure that the speech, if possible, the whatever preserved function that is still kind of like preserved, then we try to make full use of those function and try to speak if possible. If let's say it's difficult, then prosthetic management might be required. For example, like voice amplifier for those who can't really speak loudly. Palatal lift, which I will show later, what is it? Or palatal augmentative prosthesis. Augmentative and alternative communication, as shown at the side here. You see the iPhone with pictures here. It's really up to that level whereby really can't express verbally. You can either write, you can even like press on those pictures to express for you. This is what we mean of like alternative communication, not through verbal, not through speaking, but through maybe devices. They are high tech, low tech. Low tech, for example, just a piece of paper, then you just write your needs. Surgical management, for those who experience like a voice box issue, vocal cord not really moving well, then we can perform vocal cord medialization. So this is prosthetic devices. Okay, this is done in Singapore as well. Not many institutions in Singapore perform this, but there's one clinic called the Prosthetic Speech and Swallowing Clinic in the National Dental Center. Actually, I set up together with a prosthodontist called Dr. Teo. He's now the assistant director in NTC. So what happened is that we work together. We discuss on what are the best prostheses suitable for patients. So if you look at this first one, palatal augmentative prosthesis or palatal drop, we call it. This is on the right-hand side. You realize that from the side angle, it is very thick. And this is meant to be thick because it is hooked up onto your upper teeth. You realize that all this wire is supposed to hook onto your teeth. Then all this is supposed to make it thick so that your tongue, for example, like the tongue is very limited in movement. You can still contact it even though you can't reach up to the actual palate. But right now you bring it down for the palate to reach. All right. What about palatal lift? Palatal lift refer to this part on your left-hand side. See this extension? This is supposed to be the plate whereby it lifts up the soft palate. So why do we need to lift up the soft palate? Okay, here we go. So if you look at the picture here, palatal augmentative prosthesis is referring to like if the tongue need to say, for example, the ker sound. This is for the ker sound at the back of the tongue, moving up, approximating the palate. But what if, let's say, the tongues cannot move so well? So these prostheses act as a palate, but it is like a denture, but a thicker denture. Bring it down the surface, then the tongue, because there's a limitation, it can reach now. So potentially, having this prosthesis in can facilitate a clearer speech production based on the remaining function that the patient have. Okay, so as you look into this picture here, you realize that actually this is like a piece of like a thicker dentures but extended all the way to palate so that the tongue can reach. So how do we make this? The dentist will put an impression all the way in and like a plasticine actually. Then ask the patient to use the tongue to push as much as possible, then we get an impression of the tongue. This is how much the tongue can push. So basically, it's exactly how much the tongue can contact. So it's actually a full contact of the tongue and the palate when the prosthesis is in. On your right-hand side, this is what we meant of like palatal lift. When the soft palate, which is around here, stop moving, food can enter the nose, or voice will start to leak out. Your speech sound will start to leak out from your nose. So you will start to hear something like the nasal sound. This is just an example of like a nasal speech. So what happened is that when you put in the palatal lift, it will push the soft palate up at this level. It will help to close off or minimize the opening. So it might minimize the nasal sound and someone may speak more clearly, all right? And then potentially might help to prevent food from entering the nose that much. All right, so this is something that actually we can do in Singapore. So for those who are from overseas, you may want to consider approaching some of the prosthodontists there and ask, if let's say you see head and neck cancer patients or even people who went through radiotherapy to the head and neck, you can consider using this approach. So what about medialization thyroplasty? So this is done by ENT, not me. But sometimes I facilitate ENT in holding the scope when he's performing the procedure. So when one side of the vocal cord, let's say, in this case, this arrow is showing that the left side of the vocal cord, actually in this case, it's actually left side, although it's your right side, is not moving. So this side is still moving. So it can come all the way to the center, but there's a big gap. So the voice will sound like this. So there's no voice. It will sound breathy, all right? So what happened is that this is the gap, so such a big gap, right? So we want to close off the gap. What do? We can use either one method that I showed earlier. Push this part to the center. One is to inject something to bulk it up, to make it fatter. So when it reaches the center side, when the other side, which is moving, can approximate well, the voice usually can be better. Not all the time, but usually. Those cases I've seen, I performed together with the ENT, the outcome is quite impressive, all right? So, for example, you can actually inject something like this into the vocal fold, then bulk it up, then the other side can approximate. Another way is that create opening at the thyroid cartilage at the throat area there, here. Then you implant a silicone to push the vocal cord to the center. Then when both vocal fold can reach, then voice can be produced. All right, what about swallowing impairment when it's mild? How do we deal with it? We can train swallowing strategy to ensure that swallowing is still easy or safe. we try to teach swallowing exercise because even though science has been shown that, there's already this indication to show that swallowing is affected, but we also hope that it can be prevented to worsen further, okay? Or we try to preserve the function as much as possible. It is still better to do something to maintain the function than not doing anything at all, all right? So you may require some diet or fluid modification. So in this photo, this is a unit that I like to use in treatment for patients with NPC, because it can show the way they function in the laptop, and then generally to teach strategy, this is so much easier. All right, this is called the SCMG biofeedback. I trained other speech therapists to perform this. I'm a trainer in this region, so this is to train swallowing. This is to train on the oral motor, but oral motor usually is not necessary for cases with radiotherapy. It's more for, not for the lip, but the tongue, yes, but this is not so much for the tongue. Swallowing exercise, then it can be reflected, then the patient know what they're doing, and then we can set the goal, and they keep pushing themselves beyond boundary. It's basically just like a virtual dumbbell. All right, it's like a virtual dumbbell. I call this the swallowing gym. I personally call it swallowing gym. It's like a dumbbell because we can't hang the dumbbell here and do swallowing exercise this way. So this way, you push the patient to swallow as hard as they can. So from there, then you hope that you will bulk up the muscle, you make the muscles stronger, or you use it to train swallowing strategy. And if the swallowing condition become moderate, meaning that still can eat but requires some modification, then the patient might be eating modified diet, for example, like those blended diet as shown here. And a patient might be taught swallowing strategy like airway protection strategy, or even hit turn or hit tilt, all these exercises. And swallowing exercises, same thing. Even though it is severe, moderate, still do something rather than not doing anything, all right? Prosthetic management, I think that is important already. You just imagine one thing. If the tongue already showing sign that cannot approximate the palate, so basically the tongue is not pushing against anything. So there's no resistance at all. It's just like us. When we speak, right, we can regulate our tongue pressure towards the palate. So as we push, actually the muscle use strength because you push against resistance. But what about if, let's say, it's just hanging and not reaching anything? I believe that the muscle fiber might start to deteriorate even faster because there's no resistance at all. So if you put in a palatal prosthesis and the tongue can approximate, the patient can actually constantly do a push against the prosthesis. And this itself is an exercise. So there are some old literature that shows that actually doing prosthetic sometimes help with even the oral motor exercise because there is something to push against. So surgical management might be required, especially, for example, like for the medialization or anything. Severe swallowing impairment. So we still encourage swallowing exercises as a maintenance exercise. Composite strategy if possible. Well, just now I show you the VFS. The patient can swallow with water and then food can go through. If there's no compensatory strategy, right, that patient actually is labeled as severe as well because food cannot even get through. It all gets stuck in the throat. But because of strategy, it works. So swallow is still possible. So this patient actually still eating because he was taught to protect the airway and at the same time to deal with the food that is stuck in the throat. Then food can still get through. Then he's still eating, although the swallowing impairment is severe. So prosthetic management usually required for this stage. Surgical management, I mentioned earlier, or oftentimes, if let's say not possible to continue with oral feeding, then it's nasogastric tube or the PEG tube. All right, can speech and swallowing function be preserved after radiotherapy? Well, this is a very important question, isn't it? Let me share with you. Swallowing preservation exercises. This has been introduced for, now I think this is the in thing. Head and neck cancer, as long as it's radiation to the head and neck, this will apply as well. NPC cases, same. It refers to a set of exercises with the aim to maintain the movement of the range of motion of the oral, the throat, and the voice box. So all these are important for speech and eating. to learn this, please consult your speech therapist or pathologist to learn this. All right. So I don't think I can really train this here because of time limit. Swallowing preservation exercises can be performed before, during, and after completed the radiotherapy as well. All right. You can start to do before, during, and after. Even though after many years later, keep doing it like a daily routine. Then learning SPE through telepractice session, it is actually possible. There are different types. There are some actually it's possible to do through telepractice. I've done some for some of the overseas patients. All right. In summary, speech and swallowing difficulties might occur before, during, and after radiotherapy. Consult a speech therapist even before starting a radiotherapy, and learn and start to perform swallowing preservation exercise even before, during, and after completed the radiotherapy. So, thank you very much for coming by and tune in. So, I hope that you find this live presentation beneficial. And if you want to download the handouts, you can visit the website, or you scan this QR code. All right. So you can visit my blog at www.dysphagia.sg. You click under the blog. I will try to upload tomorrow or tonight if possible. Okay. So this is my email, my contact, if you want to WhatsApp me. And this is 20dB. The toll-free number, if you want to call them for more information or about hearing aids information, or WhatsApp them. Well, that's it. That's all from me.
Thank you so much, Junko and Wailam, for a very informative session. Yeah, so Wailam, personally, for myself, I think the highlight about swallowing exercises for preserving the swallowing function in patients with NPC, it really I'm very encouraged to hear about that. And I think for myself as a speech therapist, I think this is something that we should lobby, or we should create more awareness, especially while working at our workplaces, while working with the ENTs and also our patients. So for that was the highlight. It really reminded me about not just touch and go, but really work with our patients, in the rehab process. I do have a question here. We are now going to take some questions from our viewers. And okay, so the first question about trismus, the jaw opening, can it be improved with therapy?
Actually, there's some therapy, like the traditional one is to use like 3 fingers to measure whether our jaw is really opening well. Then you can try, and then we try together so that the viewers can see also. Usually we can fit in 3 fingers into our mouth. This is called a 3-finger test, you see. Our own finger, of course. If I put my fat finger into your mouth, I don't think it can enter. So if you start to realize that you can't put in 3 fingers into your mouth, actually that might be an indication that there might be some sign of like trismus. If let's say it's only 2 fingers, right, it is still possible to do prosthesis. Or in fact, if let's say this reminds me of thing, you know that when you do want to do prosthesis, like I mentioned earlier, you need to have at least 2 fingers. Okay, opening. Less than 2 fingers, the prosthesis cannot go in because it's quite thick. All right. So maintain the jaw opening is important because we have seen very severe cases whereby they can't even open like this. Okay, so how do we improve that? There are exercises, for example, like those jaw stretching. The traditional one is they use tongue depressor, they stack up, and possible then they continue adding in. But this one, please, for those who are experiencing this, please consult your speech therapist to perform this, because end of the day is if the muscle is fibrosed, right, you have to manage it carefully because fibrosed muscle can break also. So you don't want to like put in, then you try to pry open all this. No, try not to. Do it gradually. And also, there's another thing is that you can get some device called like the terabyte to try to like work on opening the mouth, the jaw. So terabyte is another thing to consider. Okay, so certainly you can use all this method because it has been shown that actually it helps to improve the range of the jaw opening. Try to avoid, prevent it from worsening. If let's say there's a sign to show that there's already a sign of like the mouth getting smaller and smaller, prevent it from getting worse. Yep. Any more questions?
Okay, I think I have one more question here. I'm going to show it on the screen from June.
Yep, sure.
If there is a severe difficulty in swallowing during radiotherapy, which is preferred, NG or a PEG?
Oh, good question. All right, it really depends because if the condition is just started, then oftentimes, right, based on my experience in Singapore, is that Asian is Asian. We when you talk about like need the surgery, a keyhole surgery at the stomach to put in a tube, right? They take some time to process. So usually we talk about NG tube first, then make an attempt to do something like exercise and then see whether it helps or not. If it doesn't really help to improve on the swallowing function, then perhaps we can talk about like this might be a long-term thing, then consider PEG. So immediately, oftentimes it's not that we don't want to encourage PEG. Sometimes you see patients come in, the moment, usually in Singapore, is that the moment they see us, right, from our experience, that it is not a mouth swallowing problem. They're already self-compensated at home. They try to flush with water, everything. Then until they really cannot eat, then or maybe we only see them when they have already start to develop chest infection. Then only discover that swallowing is already severe. So by then it's a bit hard. You can mention about PEG, but oftentimes at the acute stage, here we use NG tube first. Then when everything is established, you did a VFS, then you realize that nothing seems to be like functioning as well. Swallowing, based on our clinical judgment, it seems like safe swallowing is very hard to be established. Prognosis might not be that great based on the presentation. For example, there are some cases whereby there might be fibrosis potentially at the cricopharyngeal opening, cricopharyngeal muscle. And usually for those situations whereby PG might be a better suggestion. Yeah. Yes, any more questions?
Yep. Thanks. Thank you, June, for your question. We have another question from Danush. Can you tell the swallowing assessment protocol and assessment tools that you use for NPC patients?
That's a good question, actually. Well, there's no specific swallowing protocol. It's still the clinical baseline evaluation. You see, the thing is that NPC cases, those patients who present with speech and swallowing difficulty, they went through the radiation, and oftentimes they develop what we call bulbar palsy, which is cranial nerve palsy at the lower level, lower motor neuron problem. So we do all the cranial nerve assessment. For example, if let's say there is, I can share a screen on a video, and for example, like if there is, I hope that I can open up the video soon. So what happened is that if let's say you see like the tongue fasciculation presentation, okay, then what happened is that could be an indication that the cranial nerve 12 is affected. So based on this, then you know that actually the impairment is at the lower level. Then from there, then you can start to do hypothesis on like the potential impact on the swallowing or the speech. So from there, you can start to plan your treatment. And also, if you are understanding the radiotherapy effect more, then perhaps the stretching of the tongue might be one of the treatment options to consider. So I'm going to show you now tongue fasciculation. Then you have some idea of like, okay, so it's just for interest. People usually more visual, they prefer to see video. So tongue fasciculation refer to like a wavery tongue like this. You see that there's a lot of like movement on the tongue. So usually these are the indication of the lower motor neuron cranial nerve 12 issue. All right. So if that is seen, then oftentimes the condition is not really that reversible. Okay. in that case, then you can consider like maybe prosthetic management. If let's say there's still some movement, then we try to lower it down for the tongue to approximate. So hopefully it helps with the oral phase if the pharyngeal phase is not affected that much. Assessment, one thing I would advise is that because of the poor contraction, right, the way to assess might be slightly different from the way to assess stroke patient. Because a lot of these patients after post-radiotherapy, because of the weak pharyngeal contraction, thicker texture oftentimes is really difficult for them to swallow. Just now, my VFS, you can see that how hard for food to get through the cricopharyngeal area or the upper esophageal sphincter. So when you assess, when a patient not swallowing well on thicker, don't stop there. Try your best to see whether if, let's say, thin fluids works. And even when you do VFS, thicker not well, that doesn't mean that thin fluids will not perform well. So try your best to at least try a little bit and then see how the swallowing present. All right? I hope that answer your questions. All right, any more questions?
Yes, one more from Siu Yi. For severe NPC patients who have totally lost their laryngeal elevation during swallow, is there anything we can do about it other than tube feeding?
Well, Sylvia, I believe that you are one of the speech therapists, right? Good question, actually.
Yeah, she is.
Oh, she is. Oh, where is she from?
Kuching.
Kuching. Very well
Yes.
asked. Okay, good question. Laryngeal elevation leads to UES opening and epiglottic retroflexion, isn't it? All right. But then again, don't forget, laryngeal elevation itself is only part of the swallowing process. Okay. Unfortunately, for sometimes after radiotherapy, because of the muscle fibrosis, the lack of flexibility in the muscle, that kind of like restrain the laryngeal elevation. Epiglottis might not be retroflexing, the flap that protect the airway, but don't forget, we have 3 protectors in the airway. So we have got our false vocal fold, we have got our true vocal fold. So just now the VFS, if you recall back, or maybe you can play back after our live because the video will be there. Okay, what happened is that the patient actually making full use of the the true vocal fold to protect the airway. So you know what it is, it's super supraglottic maneuver. And then at the same time, you have to train it so well that the patient can actually coordinate between the fluid flush, everything, so that the water won't enter the airway so much or try to prevent it from entering. So laryngeal elevation, if we think that is due to muscle fibrosis, even if you perform the C-tie exercise or shaker exercise, it might not help that much. So why not focus on compensating? We see what else can we do based on the preserved function, the remaining functions, and we try to work from there. I think that will help better. I hope this answers your question. Okay, any more questions?
All right, thank you, Siu. A question from Stephanie. She has a patient with NPC prior and recently suffered a brainstem stroke, resulting in complete paralysis. What type of exercises or approach can you recommend?
Well, I suppose medical condition is very hard for me to decide, because end of the day is that you have to remember NPC prior, meaning that we need to get a lot of medical history. Whether before the brainstem stroke itself, were there any swallowing difficulties? Even if, let's say, prior there was already mild, right? Then we have to consider now the brainstem stroke itself. What kind of brainstem stroke? Pontine, midbrain, or lateral medullary? Different type. If lateral medullary, it caused very significant coordination issue. If, let's say, coupled with like an existing swallowing difficulty, I can say that it's going to turn into a very severe swallowing difficulties. So, not easy for me to answer this question now. Complete paralysis, resulting in complete paralysis. Okay, what approach? Do a VFS first, understand more about this swallowing condition, and also you must gather a very comprehensive history from the patient or the family, whether there's any dysphagia. Then from there, then I would say that you try to work towards like, actually all the swallowing exercises is possible. get from the VFS and then see. One way is to think about this is that try to think of like what function that you can work on first that potentially can bring the patient to swallow again safely. Okay, work from there. If you say complete, meaning that I presume that from mouth all the way to throat, all are affected quite significantly. So, not easy for me to answer here. I need to understand the condition. Okay, and I would say that brainstem stroke, oftentimes SCMG biofeedback is quite effective. And you have to make sure that the patient know how to initiate a swallow first. Okay? Okay, any more questions?
Thank you, Stephanie. Due to time, I think we can only take one more question. Possibly, Jungkook, can I Jungkook, can I put you on? Yeah.
Yeah, sure.
A question by Lim Gi Wee. So he is saying that he sweats a lot during the day, and is it okay to put on the behind the ear hearing aid?
Okay, Mr. Lim, of course you can put on the PTE, but what you need to do is you need to work harder on the maintenance side. So actually there's accessories to help you to protect this. There's one thing we call ear gear. Okay, this is actually it's a cloth to protect the sweat go inside your hearing aids. On top of that, you also can put your hearing aids into a dryer. It's either the silica gel or also the electrical dryer. You can get all this at our Shopee or Lazada website to get it. Yeah.
All right. Okay, thank you, Jungkook. Thank you, Lim, for the question. We have come to the end of this session, and I would like to thank all of our viewers for the questions. And if we have not been able to answer your questions during this session, we'll try to get back to you via chat, or we'll try to contact you to answer some of the questions. And if you have any questions that you still like to ask, and please feel free to contact us. I think we have our contact numbers and WhatsApp or email that is in the above the chat box. Yeah. So that's
Okay,
about.
I've got something to add. Hang on, Mandarin.
Yeah.
The NPC support group president is just online chatting with me right now. She's actually encouraging, if let's say there are any NPC survivor internationally who needs kind of some support, right? Actually, he encouraged to contact the Singapore NPC support group, and actually they actually will provide support and help, and it's free. Okay, he says it's free. His name is Dave. All right. Okay. So
how do our viewers get into that, Wailam?
I'll provide more in my blog, because right now I don't have the information. So I just got the information from him. So I will please visit my blog. I'll put all the details there. If let's say you all need some help with NPC support, then you can consider the Singapore NPC support group. Yeah.
All right.
Okay, I'll indicate in my blog together with the handouts. Okay, that's all from me.
Yeah, thank you so much. And on behalf of 20dB and Speech Therapy Works Singapore, I'd like to thank Wailam and Jungkook and all our viewers today for spending the time together. It's been very informative and very encouraging to see so many with us today. So with this,
thank you, everyone.
Say good night. Thank you, everybody.
Thank you. Bye.
Bye.
Good night. Yep. Stay healthy. Stay safe. Bye.
Yeah.